All right, good evening. This is Shankar Poncelé. I am one of the co-leaders here of the San Antonio Free Market Medical Association chapter. And as always, we are very excited to have you here and to have an exciting and interesting presentation by Dr. Bricker. I'm very happy that we were able to network a little bit and test run this AirMeet application here. I think it's working quite well so far, so let's hope that keeps being the case. A little bit of housekeeping. On the right-hand side, you have a few interactions that are available to you. I'm not sure if it is on the app, but it is certainly the case when you use the laptop or the computer. You have a general chat, which you are more than welcome to keep using. You have a Q&A section where you are encouraged, as we go through the program tonight, you can post your questions and others can upvote them if they think that is a good question. And then towards the end, we will go and address those questions. Dr. Bricker most likely will. There will also be the opportunity to join him on stage when he takes your question, and we'll see if we want to do that at that point. It's probably up to him. Let's maybe I will talk a little bit about how surprise billing has impacted me personally. I came to the US as a student in 2011 from a single payer country, Luxembourg. I had never had to think and worry about anything when it came to paying for my healthcare, which has its pros and its cons, of course. But then I went to the student health center at Miami University and I had some back pains, nothing too bad, I believe, but they did want to get a scan of my back. So the only hospital in town was McCullough Heights, and they sent me in there. So I walked into that hospital and got the scan done, talked briefly to a rheumatologist, and went back to my dorm a few days later. I must have been in that hospital for 2 or 3 hours, I think. A few days later comes a surprise bill in the amount of several $1,000s. And my student health insurance wouldn't cover that, and I was completely in panic. And I think the topic tonight addresses that issue and others, of course. This goes further than that, but I did want to explain to you why this is relevant to me. At least back when I was a student, I had firsthand experience with that. At this point, I'll play a video for you that we have prepared. As you may know, I own and run a healthcare marketing agency, and we like video a lot. We have a sponsor that has really helped us a lot financially to make this happen tonight. So Eagle Care Health Solution has sponsored the following video. I'm going to show that to you now, and we can enjoy that. It's short.
San Antonio FMMA invites you to our virtual quarterly meeting on March 3rd, 2022 at 7 p.m. Central Time. Engage with us as we are hosted by Eric Bricker, MD, to discuss the health insurance industry and how we can start a healthcare revolution.
The No Surprises Act took effect on January 1st of this year, 2022, and it specifically relates to out-of-network providers.
Over the years, I have listened to people's comments about the problems with their health insurance plans. I mean, here's a guy who's been doing insurance for a lot of years, realizing that insurance is the problem and taking another route. And that's not an easy thing to do. So whatever your challenges are out there, know that you can do it, but you got to take that first step.
Join us on March 3rd at 7 p.m. for San Antonio FMMA's virtual quarterly meeting. This message is sponsored by Eagle Care Health Solutions.
Okay, well, that went well. Yeah, if you are interested in such a beautiful video, talk to me and my team. We can make that happen. Shanks is also sponsoring this event, and we put in a lot of effort into this. So I will just very briefly give a plug about something that I am working on, a academy to teach physicians how to market themselves online, independent physicians. That is going to happen on August 9, and you can go to shanksacademy.com if you're interested. Andrea, if you will, you can put that link in the chat. The other sponsor of tonight is, of course, DirectMed Clinic with Dr. Roger Mochigamba at its helm. And he of course, is the brainchild of, the FMMA chapter here in San Antonio. Is his brainchild. So he is really the one that came to me and said, I think we should make this happen. And if you have ever spoken to Dr. Roger Mochigamba, you know that he's very, very passionate about creating something here in San Antonio that I will let him explain, because he can do that very well. I will bring him on stage right now, and then Dr. Roger, the virtual floor is yours.
Hey there. Thank you, Shankar. First of all, I want to say thank you to you and Shanks for co-founding the San Antonio chapter for me. I want to say that what I really like about Shankar and his company is that they learn about their clients, and they put their heart into marketing for their clients. And if you are lucky enough to have them market for you, you're fortunate. But back to the vision of the FMMA in the San Antonio chapter, I have a direct primary care clinic and am involved in creating value for individual patients and for employer clients that use this model. But it doesn't stop at me and my clinic. There are other direct primary care doctors, and there are other direct care specialists, and so there's a need for what we provide, and there needs to be a community for the payers to find us and to know what we're all about, and to know that we're out there. So the whole vision of the FMMA in San Antonio was to bring together doctors, bring together employers who pay for healthcare, and then bring together brokers that have the best interest of their clients at heart. And with that combination, we can provide affordable healthcare. So that's what we're all about. So I'm so thankful for all of you that are taking time out to join us tonight to hear Dr. Bricker and to learn more about affordable care and learn from Dr. Bricker. I wanted to say that ever since we started the direct primary care clinic about 4 years ago in San Antonio, we quickly learned that we had to do a lot of education for people to understand what we do, because most people are so used to the traditional model. So this was another platform for us to provide education. And I so much appreciate what Dr. Bricker does, because he is so much of a teacher about what goes on in healthcare, whether good or bad. He gives us a really good look under the hood, and is a great teacher in explaining some of the complexities that we find in it. So we're really fortunate to have him here. And thank you to all of the participants tonight for joining us. Please, if you're not already a member of our chapter, consider signing up so you'll be informed of future meetings. So I'll turn the time back over to Shankar to introduce Dr. Bricker. Thank you.
Thank you so much, Dr. Roger. Yeah, Dr. Bricker is really a very, very interesting man. Most of you probably know him. I know him because of his videos, and because of his daily emails that he sends to me. And it is really interesting to realize that by being so engaged in providing education, people feel like they know him. People like Dr. Bricker are very, very important in this ecosystem because of people like me who are not medical professionals, who came into this realm of healthcare here in the United States, not understanding everything. And if you have ever seen one of Dr. Bricker's whiteboard videos, you know that he really has an excellent talent in breaking complex topics down and explaining it to the layman and also to experts, I am quite sure. And that is just very, very important. That is at the core of what the FMMA also does, is educate so that people can make informed decisions. So I will invite Dr. Bricker to the stage, and then he can proceed with his presentation.
Well, thank you to Eagle Care. Thank you to Shanks. Thank you to Dr. Roger. Thank you to Shankar. Thank you to Andrea and you guys for all being here and listening to this. All right. No surprises act. So go to the next slide. A little bit about myself. So I started out my medical career in the late 90s as a hospital finance consultant, working back in the billing and business office of major medical centers, because in the late 90s, of course, that's when HMOs were ruining the practice of medicine. And every doctor that I talked to said, whatever you do not become a doctor. I don't have any doctors in my family. I come from a long line of engineers. And I said, okay, I'm going to learn about this billing shenanigans and HMOs that's ruining the practice of medicine. So I was a hospital finance consultant for a couple of years. And I said, after doing that, I still wanted to be a physician, but I saw how terribly messy it was, not only for doctors and hospitals to get paid, but also for the patients who were caught in the middle. So I was living in Chicago at the time. So I went to the University of Illinois for medical school, did my residency at Johns Hopkins in Baltimore, because I'm actually originally from Maryland, and I had the opportunity to go there for residency, so I really couldn't pass it up. And then moved down to Texas because during my residency, I actually started a business. I had to get special permission from the dean to start a business while in residency, and I moved to Texas, specifically to the Dallas area, and I worked at the Baylor. It wasn't called Baylor Scott and White at the time, but what is now the Baylor Scott and White healthcare system at their hospital in Plano. And Plano is just north of Dallas. And the company that I started was called Compass Professional Health Services because I'm an internist. And as an internist, I saw basically so much of the problems that Shankar was having with my patients as well. They were so confused by the healthcare system, and I, as an internist, I was trying to help them, but it was really beyond the scope of what I could do as an internist because I was helping them navigate their health insurance and how that all worked. And this is when deductibles were going from $200 to $500 to $1,000 to $2,000. This was in 2007 was when we started this business. And so we started what's referred to as a healthcare advocacy or a healthcare navigation firm, where we had actually we grew to over 300 of these healthcare navigator folks who were like on the phones and on their computers, basically acting like the coordinators for all the health insurance. We wouldn't make any clinical decisions, but we would help with all of the administrative headaches that people would have with their bills and their care and finding specialists, etc. We actually companies would put us in with those HSA plans that grew from 2007 onward. Because once the copays went away and people started having to pay these amounts, it became very confusing for them. And so we ended up growing the business to over 2,000 employer clients, including T-Mobile and Chili's and Southwest Airlines. And then we got bought. And so we sold the company. And then I started making these healthcare videos, as you know. And I then, just this past summer, ended up becoming the chief medical officer of First Stop Health. And it's been a fantastic experience so far with that. And so with that, let me pause for 1 second. If you can go to the next slide. Now, in order to talk about surprise medical bills, I have to give you a little bit of the lay of the land as far as insurance reimbursement to physicians. So payment to doctors is in the form of what is referred to as an RVU, which is a relative value unit. And everything that a doctor does, whether it be a doctor's office visit or an anesthesiologist putting somebody to sleep for an operation or a surgeon performing a surgery, each one of their tasks has a certain number of RVUs assigned to it. And Medicare and Medicare Advantage plans reimburse about $37 per RVU. Whereas in commercial insurance, like Blue Cross, United, Cigna, Aetna, that people have through their jobs, they typically reimburse higher than what Medicare reimburses. They typically reimburse about $55 to $70 per RVU. Now, when doctors send bills into insurance companies, they don't literally have RVUs on the bills. What they have on the bills are what are referred to as CPT codes. And the CPT codes then correspond to RVUs. Now, of course, for physicians, one of the most common CPT codes that we use are CPT codes for office visits. That's referred to as an evaluation and management code, or an E&M code. Now, E&M codes are just a subset of CPT codes, so there's really no difference. Now, there's also CPT codes for like what an anesthesiologist would do, putting somebody to sleep, or for a radiologist reading an X-ray, or for a surgeon performing a CABG or a gallbladder removal, etc. So an office visit has, as you can see here, 1.73 RVUs for an office visit. So you just take the 1.73 times the 55 at the low end or the 70 at the high end. That means that the doctor is going to get reimbursed by the insurance company about $95 to $121. Now, that's just what the reimbursement amount is. That is not how much the doctor bills the insurance company. What the doctor bills the insurance company is typically anywhere from $200 to $300. And then this last bullet here is where the insurance then, quote unquote, applies the discount, and they reprice the bill from that $200 that was submitted to the allowed amount, which is that $195 to $121 that they would typically get paid. Now, those billed charges can be essentially whatever the doctor wants them to be. And literally, some doctors will charge again, we had a bill from a radiologist to read my wife's MRI for $1,800, not to perform the MRI, but just to interpret the image on the MRI, which probably takes about 6 minutes. They charged $1,800. That was without the insurance discount, yada, yada, yada. So just know that the actual billed charges, that, there's no law that says you can bill whatever you want. It's the Free Market Medical Association. So they just bill whatever they want, but they're only going to get reimbursed by the insurance $95 to $121. Next slide, please. So this is where we get into the surprise medical bill problem. So doctors and hospitals always have patients sign documents at the beginning before they ever receive care that say that the patient is ultimately responsible for the bill. They will bill the insurance, but if the insurance doesn't pay, everybody, when they go into the doctor, signs something that says that they are ultimately responsible to pay. And so what happens is that a doctor doesn't have to take the person's insurance. They don't have to accept the reimbursement that the $121 that I said in the previous slide. So that is an out-of-network physician. They could say, look, I don't think that what I do is worth $121. I think it's worth a lot more than that. So I'm just not going to accept the insurance company's payment. And so when that happens, they will still submit a bill to the insurance for their billed charges. Let's say for an office visit, it's like $500. And then if the insurance company then pays that amount out, then they just pass on that amount to the patient in the form of their deductible and their coinsurance. And this is important because when a person has insurance, their out-of-network deductible is different than their in-network deductible. So when you have health insurance through Blue Cross, United, Cigna, Aetna, you don't just have one deductible, you actually have two. And so whenever you have services from an in-network doctor and an in-network hospital, those go towards your in-network deductible. And let's say you met your in-network deductible. If you then go to an out-of-network doctor or an out-of-network hospital, you start all over from scratch, from zero, with your out-of-network deductible. So this is where people will then get a bill and they're like, I thought I met my deductible. What's going on? And the answer is that yes, you met your in-network deductible, but for this out-of-network doctor that's billing you, You got to start over from scratch until you meet your out-of-network deductible. And typically the out-of-network deductible is much higher. So your in-network deductible might be $1,000. Your out-of-network deductible might be $3,000. And then even after you meet your deductible, you have to pay coinsurance, which is a percentage of the bill after the deductible. In-network coinsurance is typically 20%. Out-of-network coinsurance is typically 40%. So you've got to pay your entire deductible. And even after that, the insurance company is only going to pay 60% of the bill. And of course, the insurance company does this on purpose because the second to last point says financial steerage to their in-network doctors. Because of course, the health insurance company does not want you to go to out-of-network doctors. So they make it very expensive for you out of pocket if you go to an out-of-network physician. Now, there are some exceptions to this for state and county and city employees. Oftentimes they have very good insurance coverage for out-of-network services. Teachers oftentimes have very good coverage for out-of-network services. And people who are part of a union oftentimes have very good coverage for out-of-network services. And the reason for that is that a lot of times their salaries are lower compared to sort of the overall market. And in exchange for that lower salary, oftentimes they get much better health insurance plans. So that's not always the case, but certainly in the Northeast and the Midwest and the South and the West Coast, that's oftentimes how it works. Now here in Texas, we don't have public employee unions, so it's a little different. But just know that for some people, they don't always have to have such tremendous expense out of pocket for out of network. Next slide, please. Now, here's how the out-of-network claims processing works. So the doctor says, okay, you've got Blue Cross. I don't take Blue Cross insurance, but I'm still gonna bill Blue Cross for my $500 office visit. No discount's going to be applied. There's going to be no repricing since it's out-of-network, and it would apply to their out-of-network deductible like I just described. And that last point there, that doctor bill could be upwards of $1,800 for the service. Next slide, please. So here's where the surprise comes in, is that people will go to an in-network hospital, but just because you go to an in-network hospital, that doesn't guarantee that all the doctors that practice at that hospital are also in-network. They could choose to be out of network. And it's completely unknown to you when you walk into that hospital which doctors are in-network and which doctors are out of network. And so specifically for doctors where you don't have a choice, these doctors have realized that this is a great opportunity for them to be out of network and get paid a lot more and not have to worry about the patient not engaging them for services because the patient never had a choice. Like with a primary care doc, like if Dr. Roger participated in insurance and if he was out of network, then a lot of patients would never go see him because they're like, well, I can't afford to go see you because you're out of network. But if you're in a hospital and you're getting services from a doctor that you never see, well, then you don't have a choice in terms of being able to refuse their services. And those doctors tend to be radiologists, anesthesiologists, pathologists, and ER doctors. Next slide, please. You go into a hospital, you can't choose what radiologist reads your x-ray. You go into a hospital, you can't choose what anesthesiologist puts you to sleep. You go into a hospital, you can't choose what pathologist reads your biopsy. You go into a hospital, you can't choose what ER physician sees you. And so they said, aha, instead of settling for these insurance reimbursement rates that we don't like, we'll just be out of network and charge a lot more. Now, the private equity firms got a wind of this. And they said, aha, this is a fantastic business. So private equity firms would buy physician practices that were in network, and then they would cancel all of their insurance contracts and intentionally make them out of network. So they would buy a group of ER physicians that were in network, and they would cancel all their insurance contract and make them out of network. They would buy a group of radiologists who were in network, and they would cancel all their contracts and take them out of network. Some specific examples of that are the private equity firm KKR bought the physician group Envision for $9.9 billion in 2018 and used that strategy. The private equity firm Blackstone bought the physician group Team Health for $6.1 billion in 2016. And Envision and Team Health are huge practices of ER physicians that staff ERs at hospitals. The largest radiology practice in America, which is called Radiology Partners, is owned by or has investors from two private equity firms, NEA and Star Investment Holdings. And what happens is that obviously before the private equity firms can buy these practices, they have to buy them from the physician partners that own the practice. And so that then begs the question, why would the physicians sell to a private equity firm? Why would they provide? And the answer is why would the doctors agree to this? And the answer is that it's because the private equity firm is going to write the owners of the practice, who are the senior physician partners, they're going to write them a huge check. And typically these partners are later in their career and they're like, well, shoot, I'm going to retire soon anyway. When the private equity firms buy the physician practices, the physicians no longer receive the payments, the billings from the insurance company or from the individuals. They're paid a salary. So the private equity firm, then when they take them out of network, instead of the ER doctor charging $100, they start charging $1,800. But the ER physician continues to get paid the same amount they got paid when they were billing the insurance and getting paid $100. And then the private equity firm is keeping the difference. So in other words, let's say the ER doctor was making $250,000 a year, getting paid $100 a visit. Well, the private equity firm buys the practice, cancels the insurance contracts, starts getting $1,800 a visit, continues to pay the ER doctor $250 and keeps the difference. And the senior physician partners that sell the practice to the private equity firm, they know this is going to happen, but the check is just so big that they can't say no to it. And so this is really unfortunate for all the junior physicians in the practice who are not partners, because they essentially no longer have the opportunity to become partners in the practice, and they have dramatically increased the cost to their patients, and they themselves are not making any more money. Next slide, please. So, people complained. They complained because this started happening more and more and more. So it turns out that 20% of all emergency room visits now involve a surprise medical bill. And 9 to 16% of hospitalizations now involve a surprise bill from a radiologist or an anesthesiologist or a pathologist. So it's not the majority of the time, but it is a significant minority of the time that people are getting hit with these huge bills. Now, I'll tell you a quick story. When I was a hospitalist at Baylor Plano, we would call on a particular infectious disease consultant when we had a particularly complicated infection in a patient that we were having a hard time treating. And the patient had no choice in what infectious disease consultant I would choose. And I came to learn after doing this for 2 years that infectious disease consultant was out of network. And the patients would get these huge bills from him after their hospital stay. We, as our hospital physician group, we were in network. Now, the patients would then call our hospitalist practice and complain and be like, who was this infectious disease doctor that saw me in the hospital? If I had known he was going to charge me so much, I would have never allowed him to see me. And I had no idea. I never asked him if he was in network or out of network. I had no clue. So for 2 years, I was giving my patients surprise medical bills whenever I called this infectious disease consultant without me ever knowing. And I would tell you that for the majority of physicians in America, that dynamic still exists. They have no idea which of their colleagues are in which networks and which ones aren't. And so what ends up happening is that you end up having all of these specialists that are out of network at a hospital that are getting paid much more than the in-network doctors at the hospital. So finally, we had some bipartisan legislation where the No Surprises Act was passed in the fall of 2000. And the No Surprises Act then took effect on January 1 of 2022. So it's only been in effect for 2 months. Next slide, please. So it has a few rules. Rule number 1, an out-of-network doctor at an in-network facility like a hospital is no longer allowed to bill the patient. So in other words, they bill the insurance company. The insurance company would say, nope, it goes to the patient's deductible. You're going to have to go after the patient for the money. They would go after the patient for the money, and now they can't do that anymore. So now the out-of-network physician has to negotiate with the insurance company. And now, as you can imagine, the out-of-network doctor is going to be like, I want to get paid $1,800. And the insurance company is going to be like, no, we want to pay you $100. And there's not going to be too much negotiation there because they're both going to essentially stick to their guns. So they're going to have to go to independent dispute resolution. And the independent dispute resolution is going to have to use some sort of guide for what is the quote-unquote fair reimbursement. And the Biden administration, the Trump administration did not spell out what that guideline was going to be, but the Biden administration did spell out what that guideline is going to be. And they spelled it out as something that is referred to as the QPA, which is the qualifying payment amount. And the qualifying payment amount is the median in-network reimbursement rate for a particular geography. In other words, let's say you're one of these radiologists and you wanted to get paid $1,800 for reading an MRI. And they'll say, okay, well, radiologists in San Antonio typically get paid about $220 for reading an MRI. So the QPA is going to be $220. So in other words, the QPA is essentially the exact same thing as the in-network allowed amount. So essentially, as the law stands today, the out-of-network physicians essentially have to settle for the QPA, which is the exact same as the in-network rate. Now, as you can imagine, that is not to the physician's liking. And I'll give you another specific example. So we had this, again, happen specifically to our family, where my wife 2 years ago went in for an MRI with our insurance at an in-network hospital, had the MRI done, billed her insurance, and the radiologist fee was about $220. Next year, we have different insurance. We go to the exact same hospital with the exact same radiology group, but that radiology group is not in network with our new insurance. And so it fell to our out-of-network deductible, and the radiologist was then billing us $1,800 for reading that MRI. And of course, that's crazy. Like for 6 minutes of work to read an MRI. So I called up the radiologist's office. And I'm like, hey, I'm an internist. I actually work in billing. Like, there's no way that you can charge $1,800 for reading an MRI. That's crazy. And the head of the practice was like, so she was kind of stuck. And so she's like, okay. We'll just give you like, they actually gave me a better deal. They gave me the Medicare rate, which was even lower than the commercial insurance rate. But that was only because I called and she just like felt like being nice. Like she didn't have to do that. She could have stuck to her guns and been like, nope, you got to pay $1,800. Sorry. Because my wife signed something that said that they will ultimately she was responsible for the bill no matter what. So anyway, next slide, please. What happened was that obviously physicians that like, especially the radiologists, anesthesiologists, pathologists, and ER doctors didn't like that because they wanted to keep sending out-of-network medical bills. And so what happened was that the Texas Medical Association sued the federal government and said this QPA rule is not okay. And believe it or not, they had a federal judge agree with them. And the federal judge was like, you know what, having the QPA, which is essentially just the in-network rate, that is not an adequate quote-unquote negotiation amount between the insurance company and the doctor. And that ruling literally happened like last week. So as of now, we don't know. Like, we have no idea what the negotiated amount is going to be between the doctor and the insurance company. All we know is that the fact that the doctors cannot bill the patients still stands. So the patients are taken out of this. They're taken out of being caught in the middle like they used to be. So right now, there's a whole bunch of out-of-network bills that are not being sent to patients that are being quote-unquote negotiated between the doctors and the insurance company, and that has not come to resolution. Next slide, please. And that's a whirlwind tour. Those pictures that you saw throughout the presentation were of the farm that I live on outside of Dallas. And this last picture here is of my front porch. So welcome to my home. That's my view out of my front porch. And with that, I'll pause. And I guess I'm supposed to hand it over back over to Shankar to questions. But I just really appreciate everybody attending tonight.
Okay, well, first of all, wow, Dr. Bricker, you are my new role model for presentations. I mean, some say you can do it in your sleep, but you can do it while driving. I'm so impressed. And you might have seen, when we shared the screen, we have like an internal chat system, and Andrea was like, wow, he's driving. So, and then she was all crazy, of course, because I actually screen shared it, but it's amazing.
Well, I got to tell you, so my son had swim class, and I couldn't change that. So I'm doing FMMA and carpooling for swim class at the same time.
Well, I mean, we are so grateful, and that just shows the dedication you have to the movement. I am giving a reminder to the attendees that there is a Q&A feature where you can post your question, and then I can bring you on stage if you want. So far, there's one question that I have posed myself, so I'm just going to go and start with that. So I am wondering, when a doctor decides to be in network with an insurance, what is that decision process? What are the benefits of going with one company versus the other? And also, do companies allow for a doctor to be in network with multiple insurance agencies?
Yeah, so it's a great question. So the short answer is yes, and that's typically the case. And the by far the majority of patients typically have one of four insurance networks. It's either Blue Cross, United, Cigna, or Aetna. There's essentially only four major insurance companies left in America. So they typically will be in network with all four. The reason why a doctor would agree to being in network, it's because if they're out of network, then they're not going to have as many patient visits, because it's going to be much more expensive for patients to come see them. So they're just not going to have as many patients see them. And so what they're really doing is they're giving the insurance company a quote unquote discount in exchange for more patient volume. So that's why they would agree to it. And they typically agree to Blue Cross, United, Cigna, and Aetna. They typically agree to all four. And if anything, you got to understand that Medicare and Medicaid are completely separate from what I just described. So even though the Blue Cross, United, Cigna, and Aetna payment amounts are less than the doctor's billed charges, they're still more than what Medicare pays. And so for a physician, they're using their payments from Blue Cross, United, and Cigna, Aetna, frankly, to make up for the fact that Medicare pays them even less. And so when you have ER doctors and radiologists and anesthesiologists and pathologists, when they're like, well, we're just going to be out of network, what they're doing is they're like really, really, really making a lot more than what Medicare pays them. And, some of these people, like, it's not uncommon for, especially for radiologists, to make $1 million a year. So just know that when they go through this whole process, that, your average salary for a radiologist is like $400,000. But for these out of network radiologists, like, they can easily make over $1 million a year doing that.
Mm-hmm. Okay, so then my question is, if Medicaid, Medicare insurance patients pay less money, why does a doctor even put volume of that type of business in his clinic in the first place?
Yeah, it's because the largest predictor of using healthcare services is your age. I mean, many of us on this webinar, we're starting to get older. The wheels are starting to come off, right? And so if you didn't accept Medicare, your office for many physicians would be empty. You would have very few patients because so many of your patients are on Medicare. So that's one. And then two is, at the end of the day, listen, the vast majority of physicians are not like, greedy, money hungry people. I mean, they really want to help people. And if there's a person over the age of 65 who's having problems and they need surgery or they need to have stents or whatever, I mean, they want to help them. So they sort of, but they rob Peter to pay Paul. They're like, well, I want to help these older people. And so I will, and I'm not going to get paid a lot. And that's okay. But I'm going to make up for it for the fact that all these younger people between the ages of 26 and 64 are going to pay a lot more to make up for the fact that all these people over 65 are not going to pay very much.
Okay. Yeah, that makes a lot of sense. So I don't see any other questions, but if someone wants to join us on stage, maybe for a few last comments and remarks before we wrap this up, please put that in the chat and I'll bring you on.
Yeah, I just had a question that I put in the chat, but I don't know if you saw it. I just asked, do you have any thoughts on how we can discourage physicians from selling to private equity?
Yeah, that's a great question. And I was very fortunate in that the people that I went to medical school with, they're going through this now. And what happens is they're in private practice, and it literally is a very ugly fight between the senior partners in the practice who want to sell to private equity and the younger physicians who don't. And essentially what the younger physicians say is, if you do this, we will quit and you will have no practice. And the older physicians are like, after all we've done for you, you're going to leave? And they're like, yeah, because you're just going to put us on straight salary. You're going to get this huge check, so we're just going to leave. And so some radiology practices are like, okay, I don't care if you leave. And they take the check. And one of my other physician friends in Florida, his radiology practice said no to the private equity group because they actually looked out for the more junior doctors. And they're like, you know what? We still want to give the junior doctors an opportunity to become partners. We're okay with saying no to the big check. And so literally those fights happen. You know, physician meetings are always late at night after the clinic's closed. But those fights happen in the boardrooms of physician practices all over America on a weekly basis.
Yeah, I guess in business there can be creative ways to avoid that, but I do see how that big check is very enticing. Of course, in business planning, we talk about the so-called exit strategy, and I'm sure there's a lot of consultants that also do all they can to help senior physicians to sell off their clinic because they will get a nice commission when achieving that.
Yep. And so that's why what I think what Dr. Roger has done is so important. And actually, I think, you know, it's going to happen to more physicians than just, you know, primary care physicians. Like I think there's going to be more direct specialist care. It's something that unfortunately is probably going to get worse before it gets better. I'm not trying to be all doom and gloom, but it is, it's one of these things where as the senior partners in the practices get older and older, they're just like, look, I'm going to retire and I just need to get out. And so it is, it's something that I'm a Gen Xer, I'm 45, but that's where I really take it on as like my generation's responsibility to do something, you know, to not just be like, well, I'm just going to take a big check from a private equity firm and call it a day. Right. Mm-hmm. I feel like we got to do something to save our profession.
Yeah.
So, this is only a small step in doing this tonight, but that's why I'm so inspired by people like Dr. Roger, and there's a lot of other doctors out there who are like, look, it doesn't have to be this way. You know, it doesn't have to.
Yeah, I agree. I'm a physician too, and I'm actually a direct care specialist. So what you were alluding to, I think is true, but I think that the newer generation of doctors is very interested in cleaning up healthcare when we become aware of this. I think the thing is that my husband sitting next to me, he's a ICU physician who was like, I had no idea this was a thing. And it's like disgusting, you know, and it's like, you know, the private equity buyouts. And so I think the more of us that know, the better. So thank you for what you do to educate all of us.
If they upset the apple cart, then their physician colleagues are not going to send them referrals anymore. You'd be like, well, then fine, I'm not sending you any patients anymore. And so there absolutely is nepotism and punishment for keeping your mouth shut and keeping your head down, and you'll get consults and referrals. And if you start making noise, then you get blacklisted, and you don't get patients anymore. And I've absolutely seen that happen.
It looks like we have had a good conversation. If there's anyone else that wants to join us here, let me know in the chat. If not, I think we can wrap this up. And I really want to thank everyone for attending. It's been a great meeting, and I am very inspired by these positive movements here in our FMMA association and in our our just willingness to do something better in the healthcare system here in the United States. So thank you so much. Stay in touch, connect with each other on social media, continue the conversation, subscribe to Dr. Bricker's newsletter, and connect with him on LinkedIn as well. And have a great evening. Bye for now.